Hello, good evening, everyone. I welcome you all to another webinar under Society of Pediatric Cell Therapy and Transplant. So, today we have an interesting webinar with two rare complications of transplant. So, one is that eye GvHD, and other is when you have gut GvHD, what newer treatments or what else can be done when everything else has failed. So to discuss these rare complications, we have great speakers and panelists lined up for a discussion later on. So first of all, I would like to introduce today's chairperson. I would like to invite Professor Dr. Tulika Seth, who is uh, professor and senior consultant at the hematology department in AIMS, Delhi. And ma'am is here and she will take charge of today's webinar. So welcome, Dr. Tulika. Please take over and introduce the speakers. Thank you.
Thank you so much. Thank you, Dr. Satya and Dr. Satyendra. This is a very important webinar series. I'm delighted to be here. I'm delighted to invite Professor M. Vanati. She's Professor of Ophthalmology at our reputed RP Center at AIMS, New Delhi. She's in the Corneal Lens and Refractive Unit. She's editor-in-chief of the Indian Journal of Ophthalmology and the first woman editor, I might add. She's a council member for the Afro-Asian Council of Ophthalmology. She has received numerous awards, and very recently, one of her students won the best paper award for his work. Ma'am has over 300 papers, more than 80 chapters, and she's written a book which is now in the third edition, and over 250 presentations. And I think the most important thing is that the work that she does for us in chronic GvHD is absolutely world class, and I'm delighted to have her on this platform to share her knowledge. Over to you, Dr. Vanati.
Thank you very much, Dr. Tuleka, for the kind introduction. I'll proceed with sharing my screen now. Okay. Am I visible and audible?
Yes.
Yeah. Okay. So I think over the next 10 minutes or so, I will just share our experiences of managing ocular GvHD. I think our journey started almost a decade ago when Dr. Tuleka and Dr. Mahapatra and Dr. Pravas Mishra sent across their initial patients who had eye problems with following hematopoietic stem cell transplants. And that's when we started looking at how we could probably help out these patients. I have no financial interest in the mention of anything during the course of my talk. Yes. So I think I'll skip all the theoretical aspects of ocular GvHD, and I think all of you know that eye is among the other systems which is affected in when a patient develops GvHD following a hematopoietic stem cell transplant here. And the reported incidences range between 25 to 45% here in among blood and marrow transplant patients. And ocular GvHD, according to world literature, ranges between 60 to 80% or above of patients who have chronic systemic GvHD. Dry eye disease being the commonest clinical manifestations of these patients who undergo this. And I think in our experience, we've seen it more in patients who have undergone allogenic hematopoietic peripheral blood stem cell transplants rather than bone marrow transplants here. So her initial experience was way back about a decade ago, and I think there was no literature on ocular GvHD in the Indian scenario here. And we looked at all the allogenic hematopoietic stem cell transplants and to look at the epidemiological prevalence of this disease among our patients who undergo hematopoietic stem cell transplants at AIMS New Delhi. And we found GvHD occurring in about close to 45% of the patients with risk factors being female genders, multiparous donors, older donors, and those who had had cytomegalovirus reactivations. Ocular GvHD is occurred in about 32% of the GvHD patients, with the mean time interval being about 18 months in our group of patients here. And it is interesting to note that ocular GvHD occurred in over 85% of those patients who had chronic systemic GvHD here. And we all know that once the skin and the oral mucosa is involved, then the eye involvement is almost always there here. So that's what I think we looked at, and much of this is already known to you, but what's changed the way we are looking at the management of ocular GvHD patients is that now we have targeted topical therapies here to help these patients and to probably cover the pathogenesis which is affecting the ocular surfaces of these patients. So that's how management has changed. But before I go on to the management here, I think I'd like to share some of our data which we looked at, and we shared our data in a multi-centric study with the Asian group of people who are Asian groups and certain other groups who are working on ocular GvHD to look at the validations of classification or diagnostic criteria for ocular GvHD manifestations. And I would refer to you to this very interesting paper, which is authored by authors from New Delhi, from our ophthalmology branch here. And it's interesting to know that these are the two classifications which perhaps we would recommend and we would advise you to use when we are looking at the diagnostic criteria for ocular GvHD patients here. The earlier one came way back in 2014 based on the National Institute of Health criteria here. And the recent ones which came is on the international ICC classification, the International Consensus Criteria on Chronic Ocular GvHD here. So this is something which is more reliable, or which would be probably more specific when you apply to GvHD patients who develop ocular involvement, where the ocular severity grading, depending upon the ocular surface involvement, the epithelial cell involvement of the ocular surface in terms of the dryness, the Schirmer stress, which depletes their aqueous secretions here, the tear lacrimal secretions, the corneal staining scores, the conjunctival staining scores, and the ocular surface disease index scores here. So these are given specific points. And depending upon the presence or absence of other systemic GvHDs, we can then probably point out to saying whether they are having an ocular involvement, a probable ocular involvement, or do not have ocular involvement. I think this is one of the best ways of going on to have a diagnostic criteria, because several times I think clinicians tend to mix up the dry eye disease which exists in most patients. And given that ocular surface dryness or minimal dry eye disease would probably be present because of various other reasons, because of evaporative dry eye disease, which could be secondary to many other pathologies, which would be secondary to mostly like a computer vision syndrome, or because of overuse of digital devices, where they are probably reading or looking at their digital screens for longer period of time. So that would also result in a mild dry eye. And it is imperative to differentiate that dry eye disease differentiating from an ocular GvHD. I think that's where the role of an ophthalmologist is very imperative. And we have enough literature for you to look at the various clinical characteristics of ocular GvHD in terms of its diagnostic criteria, the classifications, the clinical severity grading, the varied presentations of ocular GvHD, the treatment strategies which are involved, imaging, ocular surface imaging, the prognostications, the proteomics, and objective parameters for diagnosis. So this is one very comprehensive article from us, which probably details all of it here. And some of us see patients like this, though these are not very frequent. They are quite rare. This is from a pediatric patient which had undergone a hematopoietic stem cell transplant elsewhere in Delhi, not from AIIMS here, and came with this presentation of a very acute pseudomembranous conjunctivitis here, the differentials of an ocular GvHD, but sometimes you could also have an acute SJS, Stevens-Johnson syndrome, which could be mimicking this here. So that's a differentials which one need to look at. Most of our patients with ocular GvHD would be going on to a worsening of the ocular surface dryness, And they would mimic something like other immunological diseases such as rheumatoid arthritis here. And these are patients here, if they continue worsen, their ocular surfaces are going to look like that. They do get earlier cataracts here, and they could go in for epithelial surface melts and perforations here, which need to be managed depending upon the severity of the morbidity which is affecting the ocular surface. So on the left, you could see a patient who worsened, went in for a perforation here, required a patch graft. That's a cataract you're seeing here. And this patient subsequently went on to have a cataract surgery and IOL implantation here. So these are ocular surfaces which pretty much need to be constantly looked at when their surface disease is worsening here. This is another, the next set of study. We looked at our patients after we looked at their epidemiological data to look at inflammatory markers on the ocular surface and to see if any of them can serve as biomarkers. And I think that's the million-dollar question we are looking at. And we still are yet to identify any particular biomarker because all ocular surface inflammation does not have any specific biomarkers. And this is a particularly difficult region. It would lead to an increase of a lot of the inflammatory biomarkers, but nothing specific for ocular GvHD. And from our data, we just found out that the tear VEGFs, the tear proteins are all affected, along with, of course, MMP9, but it's a non-specific marker for ocular surface inflammation here. So that's what we could study when we looked at the tear inflammatory markers. And that led us to look at how we could probably adopt the approach of targeted therapy in ocular surface disease managements here. I think much of it is more for an ophthalmologist, but we do have specific medications in terms of immunomodulators like cyclophorin and tacrolimus, which need to be used cautiously on the ocular surface. We have topical biologics in terms of derivatives from the blood and the serum here. And we have specific targeted therapies in terms of using diluted heparin. You could use insulin for neurotrophic keratopathies. And we have anti-net therapies, which would also help the ocular surfaces of those which are worsening. When we use blood-derived products here, such as autologous serum, umbilical cord serums, those actually help in providing good growth factors for better epithelial surface optimization. And that's how it can help some of these patients. But most of these are not available over the counter and will have to be prepared in-house by an in-house pharmacy. And care has to be taken that these are preservative-free drops and they do not cause infection on an ocular surface which is already getting compromised here. So that's something which we need to do carefully when you are advising, platelet-derived drops or autologous serum drops for these patients here. This is yet another review which I would urge you all to go back and read, which gives you a very good update on ocular graft versus disease, incorporating all these newer developments in the management of the ocular surface of these patients here. So autologous serum was the first generation of blood-derived projects which came into use, and it's been in use for a long time for dry eye disease or severe dry eye disease patients here. We also looked at our group of patients using autologous platelet-rich plasmas. And these are all fine variations in the way we prepare the blood-derived biological tear replacements here and autologous platelet lysate drops. So these are something, this is a third generation. We started this study just before COVID, and unfortunately, COVID did not let us complete this with only 8 of our mandated patients being able to complete the follow-up of 6 months, and hence we could not take it up to the publication. But autologous platelet lysate therapy makes the growth factors readily available for the ocular surface of these patients and really helps to rapidly optimize the surface of these patients who are otherwise worsening here. Some of the clinical pictures of our patients who underwent this therapy, and this does really help to optimize the surfaces in such patients here. Once the surface is optimized by tear lubricants, anti-inflammatory therapy, biological tear replacements, then we would probably take them on for scleral contact lens wear. So there are a subset of patients who are put on scleral contact lens wear. The patient was like this when she started with, and after a series of 3 to 6 months of wear, you could see the scleral therapeutic wear field. Scleral contact lens wear acts both as therapeutically and as a refractive rehabilitation for these patients and helps to conserve and helps to optimize the surfaces of these patients. But we do have a subset of patients here who behave like cicatricial diseases, progressive cicatricial immune diseases here. And this is a particular subset which is very, very difficult to treat. And you could see the surfaces continually getting affected, going on to look like a chronic fibrosing cicatrizing conjunctivitis. These patients, the epithelium tends to break down off the corneal surface as well, and they need tectonic reinforcements by doing deep anterior lamellar keratoplasties, by needing repeated amniotic membrane inlay onlay grafts. But these surfaces, for some strange reason, do not seem to be responding to whatever therapy we give for these patients. And that led us to look at the targeted therapy. Then came in these two wonderful papers from Dr. Sandeep Jain and his group. He is from Delhi, but he lives and works in UCLA, Chicago. And it's their group which looked at and identified the presence of neutrophil extracellular traps on the ocular surfaces of patients with severe dry eye disease, including ocular GvHD patients, where they demonstrated that the ocular surface washings have a significant amount of net traps present on the surfaces, and these induce are all responsible for the refractory nature of the dry eye disease in this subset of patients who go on to a progressive fibrotic kind of a disease. The surface anti-citrulated protein antibodies also contribute to these ongoing inflammations, which are refractory to conventional therapies of dry eye disease here. I think this then led us to look at topical immunoglobulin G therapies, that is ocular surface immunoglobulin therapy, which helps to decrease the ACPAs on the surfaces of these patients. And again, we found that these are a very effective adjuvants in managing the progressive fibrotic disease or progressive worsening of the dry eye disease of this subset of ocular GvHD patients who do not respond to biological tear replacements along with conventional therapy. So I think this has already been published in the Indian Journal of Ophthalmology for you to go back and read if you look at, and this really decreases the dependency or frequency on topical steroid therapies for our patients, and also decreases the surface discomfort here and helps to optimize the surfaces better in these patients. So that's one therapy, which again, it's not available over the counter and has to be made, formulated in-house, and comes with a certain amount of cost, where you are using intravenous immunoglobulins and they are reconstituted as ocular surface immunoglobulins for optimizing their surfaces. And these do help in decreasing the hyperemic scores and decreasing these surface epithelial damages and helping in improving the quality of life of these patients in a quite significant way. We also looked at the recent study, which we just concluded, is looked at the role of recombinant DNase drops on these surfaces, which are refractory to the conventional therapy. This was a larger subset of dry eye disease patients, of which ocular GvHD formed a significant amount, and these recombinant DNase drops, 0.02% reconstituted for ocular surface use, was prepared in-house, and this has given us some fantastic results here. We have just finished compiling and we have presented it, and probably would be hitting the journals pretty soon here. And this is something which is specific, and it acts on the surface nets which are present on these group of eyes which have refractory dry eye disease here. So that's how we have now changed the way we look at and manage the worsening ocular surfaces of some of these ocular GvHD patients here. And we are probably now, I think I just had a meeting with the International Ocular GvHD group, Dr. Sandeep Jain and his team. And it looks like they have probably hit on what will help us to prophesize which of the eyes which are going to develop our ocular GvHD, or how we can alter the way we can manage these eyes here. But I think that's still in the very early stages, and we are looking forward to learning more and sharing our results with you all in the near future. I think I'll stop here, and I wish to thank our team of Ocular GvHD, which works at AIMS New Delhi. Both Dr. Tulika and Mahapatra have been a very good source who do send their patients over to us. I work alongside our chief of IP Center, Professor Radhika Tendon, and these are all our master's degree thesis, master's degree students whose work was based on ocular GvHD, and Dr. Sandeep Jain, who shared most of his experiences with us, which helped us to work on the worsening surfaces of our ocular GvHD patients. I think I'll stop here and thank you for your patient listening.
Thank you. That was absolutely excellent. And it shows how long you've been working and how hard you've been working. And that really helps our patients. So, Dr. Satya, do we have any questions?
Yeah, I think we should let the next speaker speak and then we take questions. Yeah,
Okay.
thank you.
So the next speaker is again a very famous person. He doesn't need a lot of introduction to people in the transplant family. Dr. Sameer Melenkeri is the HOD of hematology at the prestigious Dinanath Mangeshkar Hospital in Pune. He is an author of multiple papers. He has many firsts to his career. He's got many projects. And for any of you who haven't been to the hospital, you really must visit. It is a excellent facility, and they have probably, I would say, the best electronic medical record system I have seen in the country. So aside from that, I invite you to now deliver your speech on a very interesting topic of the fecal bio matter transfer in GvHD. Over to you. Thank you.
Thank you, ma'am. Thank you for the introduction. I'll just share my slides. Okay. All right. I hope this is all fine, visible and on full screen mode. So I'm going to talk about fecal microbiota transplantation for treatment of GvHD. So I'm going to first describe what a little bit about the microbiome, and then we'll discuss about some data on FMT in GvHD. And then we will actually go on to some of the studies, what we are doing in-house, practically how you should do an FMT, and then subsequently what we plan to do in future. So, microbiota changes during hematopoietic stem cell transplant. If you look at the diversity, the microbial diversity, it starts to decline from the start of the conditioning regimen and continues to decline for about 12 days post-transplant. If you look at this figure, you can see these are the bacteroids here. The bacteroids are predominant over here, but gradually you can see the bacteroids coming down, and the blue is the enterococcus. The enterococcus starts to dominate. Okay, so intestinal domination, it kind of varies, and with the conditioning regimen, the antibiotics that you give, a good amount of the good bacteria are dead, and then you have colonization by weird bacteria. So intestinal domination is described as the occupation of at least 30% of the microbiota are by a single predominant bacterial taxon, and this can frequently happen after HSCT. That's because you kill all the rest, and one of them overgrows. And this study showed that the intercoccal domination increased the risk of VRE bacteremia. So what are the causes? Why does this happen? So you have dietary perturbations, you have TBI, chemotherapy, mucositis, diarrhea, neutropenia, and infection risk, and therefore broad spectrum antibiotic exposure, and then monocolonization. So there's a growing evidence that suggests a link between diet and microbiota. TPN can profoundly alter the composition of the microbiome. And apart from this, so just a little bit about what is the Shannon index. Shannon index is a method of measuring the biodiversity in people. So there's an alpha diversity and the beta diversity. The alpha diversity indicates the richness, in the number of species within a particular individual, the variation in a particular individual. So if you have a good variation, that's a good alpha diversity. That is good. That is a good sign. The moment the alpha diversity starts to drop down, it is a bad sign. So a lower Shannon diversity at the time of engraftment was associated with an increased incidence of acute GvHD. This is a known fact. Then another important inciting factor for the development of GvHD is actually intestinal infections. And one of the most prominent one is Clostridium difficile diarrhea. So Also, if you have CMV, you have adenovirus, if that causes intestinal, what shall I say, colonization, then you're going to have intestinal inflammation, and then the donor cells are going to home into the intestine. So C. diff is a very important cause, and it kind of begets GvHD, and we've seen this very strongly in our population. Because for some reason in our hospital, C. diff diarrhea is pretty common. We see a lot of patients who have developed C. diff diarrhea, and then that you can't realize when the C. diff diarrhea converts into GvHD. So it's sometimes difficult to differentiate. So what is the role of fecal microbiota transplant in the setting of HSCT? One, to treatment of Clostridium difficile associated diarrhea. We know that it is the treatment of choice for refractory C. diff diarrhea, and we have a paper also published to that effect. Then for the treatment of thing called restorative FMT, which I won't describe for lack of time, but just to mention that instead of treating GvHD, you can actually restore the gut microbiome before doing a transplant. If you received, say, an AML has received chemotherapy, and the gut microbiome is disturbed. So before actually going in for a transplant, you can do an FMT to restore the gut microbiome. So this is experimental, but there are some elegant studies that are ongoing to document the role of restorative FMT. So, we know that patients with steroid refractory GvHD have approximately a very poor survival. FMT restores the beneficiary functions of health microbiota by restoring the normal fecal microbes in the GI tract. The healthy gut microbiota produce metabolites and anti-inflammatory effects that can alleviate inflammation and the symptoms of GvHD. And FMT may also be involved in the regulation of immune cells that mitigate systemic autoimmune response. These are some studies which done in a smaller population of patients, where they showed that it is doable, and there are a good number of patients who actually show a complete response. And then there was one of the champions of FMT worldwide is a gentleman by the name of Florent Mallard from France. He's probably the person who has done the maximum research and studies and publications on steroid refractory GvHD. And I'll just quote one of his papers. This was published in the Lancet in 2024. This is pooled allogenic fecal microbiota transplant. They've kind of made a trademark for it. It's called MA 2013, maybe a patented for steroid refractory GI GvHD. So this is a single arm trial, predominantly in French centers, and also one or two from Germany. This is called as the Heracles study. This is very kind of cited. So the use of MAR2 in the treatment of GI predominant steroid refractory GvHD. What was this product? So pooled feces were prepared from 3 to 8 strictly vetted healthy donors and frozen within 72 hours of collection. These donors was selected based on their gut microbiome, which was studied prior. And they were chosen on the basis of richness and diversity of the gut flora, and stool prepared in the French GMP facility. There was batch manufacturing done, and then the results: 24 patients were enrolled. Most of them received at least two installations of the FMT, and some of them received 3. And out of these 24, CR was in 5 patients and PR in 2 patients. So the overall response rate was about 38%, and the complete response in about 29% patients. They also studied the phylogenetic composition using the 60S ribosomal DNA sequencing to study the alpha beta diversity. And this was done at baseline, and then on day 9, day 16, and day 28. And they looked at the differences between the gut microbial composition in responders versus non-responders at baseline and after treatment. They also did something called the beauty core, which is the butyrate producing bacteria actually help in prevention of GvHD. And this is a sum of relative abundance of the set of butyrate producing genera. This was significantly higher in responders versus non-responder patients. So some of the things that they showed, and this was a pretty elegantly done study. This is a study from our center, and this is actually in for Clostridium difficile diarrhea. But in this, we've described exactly how we perform an FMT. So I'll describe this a little bit. So assuming that you have a patient who's got steroid refractory gut GvHD, which is generally defined as progression of diarrhea on 5 days after on day 5 of 2 mg per kg of methylprednisolone, or no response by day 7 of methylprednisolone. In that case, you call it as a steroid refractory gut GvHD. The moment we have a patient who has a gut GvHD, we start screening the donors. Why? Because when you start screening the donors, it will take at least about 4 days before you actually can instill the FMT. So in our hospital, what we do is the job of the consultant is to actually counsel the patient regarding what this procedure is, what are the benefits, etc. Once that is done, we ask the patient to invite at least 2 or 3 of their or donors who they know are not suffering from any illness. They could be relatives, but not somebody who's actually staying with the patient. Somebody who's outside in the community. And these donors then visit our microbiology lab, in which the head of the Department of Microbiology actually talks to them, counsels them about what the procedure is. And then the next day, they actually donate the stool. We generally screen about at least 2 donors at a time, because if one donor turns out to be not having adequate, appropriate stool, then we can choose the other one. These are the criteria for donor screening. We should be off immunosuppressive therapy and chemotherapy, no antimicrobial drugs, no antibiotics. None of the usual things for somebody who would be a blood donor. We look at all of those things. This is pretty standard. And we also then we screen the stool for a routine examination, stool bacterial culture, modified ZN staining for Cryptosporium, Isospora, etc., and a Clostridium difficile assay on the stool. If these are negative, and if the patient doesn't have any drug resistant bacteria lurking in the intestine, then that donor can be selected. Then on the typically, supposing you screen the donor on a Monday, somewhere around Wednesday night or evening, you'll have the reports ready in your hand. And then the donor is informed that you need to donate the stool the next day morning. So say on Thursday morning, he will donate the stool, and the stool will be carried in a sterile flask. It is collected in a sterile flask and then transported to the microbiology department. At least 50 gram of the stool specimen should be there. Then the procedure is that with a wooden spatula, so you can see here donor feces, you mix it with 250 ml of non-buffered sterile saline. You mix it nicely, emulsified. It's not a mixer actually, but just to show that you emulsify it. And then you, in a conical flask like this, you put a filter paper and you filter out. You pass the stool through that and filter out all the coarse particles, so that what you see over here is just a clean, just a very clear liquid, which is sort of coffee colored. And that is then transported by the microbiology department to the gastroenterology department, where to the endoscopic suites, where it is instilled either endoscopically, either through the colonoscopic route or through the nasojejunal route. But generally, what we've now been doing is that we do a gastroscopy, and in the D2 area, the distal part of the duodenum, the stool is instilled there. So that becomes a little easier. So both of these are done, and you can decide which one you want to do based on certain factors, which I'll discuss a little later. This is a study which we had published, not published, sorry, this was presented as an oral presentation. Use of FMT this is our data on 17 patients with acute GvHD. So the idea was to look at the effectiveness of FMT in GvHD. The FMT solution was infused within 6 hours of donor voiding. That's important, that after the donor has voided the stool, within 6 hours, this whole procedure, the installation should be completed. Otherwise, the stool is going to start degenerating. The route of the FMT is decided based on the extent of the bowel wall edema sometimes on the CT scan. But now most of the time we start doing the duodenal route itself. And then the patient is kept in a Trendelenburg position. That's a slightly head low position for about 2 hours. So that if he's constantly getting vigorous diarrhea, then he shouldn't throw out the stool immediately. So if you're doing a colonoscopic installation, then we keep them in a Trendelenburg position for about a couple of hours. So the urge to pass stool reduces in this position. So the stool stays for a while, at least in the gut. So out of these patients, these were the characteristics, these were the conditions that they suffered from. And half of them were haploidentical, some were a matched sibling donor. This is the type of GvHD. Most of them had intestinal GvHD alone, but a good number of them also had other sort of GvHDs, but it was gut predominant. The GvHD was of course graded by the Glucksberg criteria, and in most of the patients, it was actually grade 4 or grade 3. Many patients were on second-line immunosuppressants, ruxolitinib. I use basiliximab a lot, especially for gut GvHDs. I've had some good experience with it, so that's what patients were on. And a good number of our patients, out of these 17 patients, 11 also had associated Clostridium difficile diarrhea. So the FMT would serve as a treatment for both of them. Median number of donors screened was about 3 per patient. Total number of FMT sessions was always 2. We do it 1 week apart. So if you do one, you repeat essentially the after 1 week. And colonoscopic was predominant over here. Nasojejunal initially less, but now we do a lot more nasojejunal. And this was the data. No response in 41% patients, partial response in 24% patients, and a complete response in 35% patients. The median time to clinical response after FMT was 7 days. And a relapse occurred in about 40% patients, and that could happen about a median of 61 days later. These are the complications: abdominal pain, vomiting, and GNB sepsis. GNB sepsis actually is very difficult to say whether it was from the FMT or not, because sometimes the sepsis occurred much later, and it could actually be just because the patient was actually immunocompromised and could have any GNB sepsis. These are the comparison with the other studies. This is the Heracles trial, which showed an ORR of 54%. Another EAP study, which is 67%, and ours was about 58% ORR. The limitation, of course, we didn't do a microbiome analysis over here, and therefore we couldn't document exactly how the gut microbiota changed. And there was no single standardized tool specimen, so we took ad hoc donors, which is what most of the times in the world it is done. But, we didn't have something like the product, which, it was a uniform product, which everybody received. So the conclusion of the study was that FMT could be an effective treatment for GvHD. Early initiation of the procedure can avoid life-threatening complications, and further studies are needed to establish the safety and efficacy of FMT in India. So now, what are we doing now beyond this? So, Shaurya, who is on this panel, Shaurya Ghosh from TMC Kolkata, he came up with this idea that, he wanted to study this systematically, and therefore we got an ICMR grant. So between TMC Kolkata and Deenanath Mangeshkar Hospital, we've got this this trial. We call it the Safe FMT trial. It is just started. So 20 patients are going to be studied. So 10 from each center, and FMT versus retrospective comparison with ruxolitinib alone. So you want to know whether the Rux, how the Rux data was, and between FMT plus Rux. So patients with steroid refractory GvHD progressing, that's a standard definition. We will start the second line therapy after steroid. We are going to use a second line therapy also. It could be anything, but it should be received for a minimum of 3 days. And if there's no response, you can proceed with FMT. Primary endpoint is safety at the moment, and secondary endpoint is going to be efficacy. And we're going to study the 16S ribosomal DNA sequencing. We are going to send it to MedGenome Lab to study the alpha and beta diversity. And that's going to be done at various time points at the time of starting the study, and then at various time points up to 3 months. So we're going to, once the GvHD is detected, it will prompt donor screening for FMT, and it may be a good jump to. So this is just to summarize that FMT can work in about 30 to 40% of patients. It should be considered. It is doable, but it requires a lot of coordination between hematology, ID, microbiology, and the gastromedicine departments. But it is not the panacea for all GvHD, but it can work in a good number of patients. So with that, I thank you.
Brilliant. That was a very lucid and wonderful talk, and that highlights why you are such a popular speaker. Thank you so much.
Yeah, so I think we can take few questions. So anyone in the audience has any question, they should type in the box and text box, and we will take up those questions. But before we have questions, I will like to ask one question each to both the speakers. So first, the IGVHD. So Dr. Vaniti, excellent talk, and it was very, very impressive. And it is such a under-treated, under-managed, not well-known entity amongst the transplanters. And that's why it's very important that this talk was kept, that people are aware. And early treatment is key. My question to you is that although chronic GvHD is common and of eye, and we do see it often, and we know how to diagnose, and we do refer them to eye specialists quite early. But acute GvHD, that's very, very rare. I have seen two cases in my career, and both were pretty bad. So, in acute GvHD, one is can you tell the audience like when to suspect? Because I think the early treatment can save the vision, but if it's too late, they may have a lot of corneal clouding and problem, and vision may be affected. And two modalities which I think should be started early, which I had a battle to explain to my ophthalmologist, like the one is an artificial lens which can be put on the eye to prevent further damage, because the kid was having so much of photophobia, and the eye specialist was not even aware, or not even agreeing to putting that. So one is comment about that, and second is I think amniotic membrane which you put in the eyes of these acute GvHD, ocular GvHD. Can you comment on those two? Thank you so much.
Okay, yeah. I agree with you that, I think I have only seen one acute suspected or a presumed ocular GvHD. It was in a pediatric patient, which was done outside AIMS. And I think that's something which I've always been asking Tulika, that I don't see so many pediatric patients, and I do not see any acute ocular GvHD. And that's perhaps for you people as oncohematologists to deliberate what is being probably differently done in terms of conditioning your patients or your management. I think I'll speak more about it subsequently. But coming to your question right now, when you look at an acute, it is an acute pseudomembranous conjunctivitis, which means there is a lot of sloughing of the conjunctival mucosa and the corneal epithelium here. So this is pretty much similar to as you would see in acute Stevens-Johnson syndrome here. And these patients will have to be treated as an emergency. They will need to be taken to the OR to have amniotic membrane transplants. So they have multi-layered amniotic membrane transplants. And this should not only be limited to the bulbar conjunctiva, but will also need to be reflected onto the tarsal conjunctiva, because raw surfaces of the inner part of the eyelid and the globe will tend to stick together. So that's when you'll have to probably go in to do a good technique of amniotic membrane covering these raw surfaces. So one is prevent infection, two is cover the sloughing surfaces here, and three, prevent the adhesions from forming again with using copious amount of ointments, or we put what is known as symboliferon shells here. So these are particular shells which prevent symboliferon, meaning adhesion of the inner surface of the lid with the globe with the eye globe. So to prevent symboliferon formations, we might need to insert what is known as symboliferon shells here. So these would be, and they are not very expensive treatments, but they need to be done timely. And sometimes they will also need to be repeated, because the membrane melts very fast in an inflamed surface here. And of course, I think you would be needing to step up your systemic therapy to decrease, because this is an ongoing systemic inflammation which is being precipitated on eye being one of the systems here. So when you do adopt this approach here, then you would probably be decreasing the morbidity of the surfaces. Of course, what vision the patient will get will depend upon the amount of damage, residual damage, which will remain on the ocular surface for these
And a
patients.
comment about lens, artificial lens, which can be put to reduce photophobia.
Yeah. The artificial lens basically is, one is if you're using a symboliferon ring, okay? Two is if the sloughing is minimal, then you have contact lenses which you can be using on these surfaces here. So those are simple. They could be bandage contact lenses here. They could be pros lenses. They could be scleral lenses, but that needs to be determined by your ocular surface, a cornea and ocular surface expert. So I think what all oncohematologists need to do is to have in their panel or in their collaborative a cornea ocular surface expert who would be able to look at the surfaces of these patients. And I also feel it's imperative that you please have get an ocular surface evaluation done before you take these patients on for a transplant, because several times there would be a pre-existing amount of dry eye because of the lifestyle changes of the patient, because of the ongoing systemic medications which are needed, because of the irradiation treatments you put the patients on. These themselves could worsen the tear surfacing or resurfacing of the places. So those don't directly go on to be treated as ocular GvHD. I have seen several ophthalmologists or general ophthalmologists who are not aware of this, misdiagnosing this as an ocular GvHD. And the patient tends to, many of these patients, as you would rightly agree, it's the quality of life which we want to become better. They are undergoing a very dire disease which they are fighting. And we would really not like to really further psych them by telling them that you've developed an ocular GvHD. So that's a concept which I always like to look at when I'm dealing with these patients. So I don't tell them they have ocular GvHD. Mild amount of dry eye disease affects almost now, given maybe 30 to 40% of the general population themselves, given lifestyle changes, given the weather conditions, given the conditioned environments we are in all the time, given the computer vision syndrome. Most of the normal people, given postmenopausal disease, thyroid eye disease, so these all do exist. So it is imperative, and that's why I always say, please have a cornea and ocular surface expert in your team. It's not just a general ophthalmologist. Yeah.
Thank you so much. It was very, very wonderful answer. Thank you. So I have one more question for Dr. Samir Melinkari. So Samir, this talk was absolutely wonderful. We enjoyed it, and I think it's a much needed field where we develop protocols and start using it more often in our practice. Most people are scared because they don't have a protocol of fetal microbiota transplant. So my question is that we, on one end, we tell all our bone marrow transplant patients to have very hygienic food. It should be like a neutropenic diet, and a lot of hygiene is very, very important. And on the other hand, we are giving a fetal microbiota transplant where we are putting a lot of bacteria and feces. So these are two extremes of. So how do, as transplants, we agree? Do you feel that we should be a bit lenient in our patients' management and allow them to have more food, and so that naturally they have more bacteria naturally going into them and protect their gut, instead of giving them like prophylactically we become little lenient and allow them
Yeah.
to eat everything? Thank you.
You're right. It's just that, when we generally talk about contaminated food, that generally contains, bad bacteria. It would be, contaminated bacteria which can cause an infection, and therefore you can't allow them to eat, bhel puri when they go out. But when you're doing this FMT, you've actually studied the stool, you've done a culture, and you've ruled out the presence of any of these disease-causing bacteria. If they have it, then you're not going to use that donor. Only if he has a good, floral diversity, which is kind of benign and acceptable, only that stool is going to be instilled. So that's the difference.
Thank you. And there is a few questions in the text box. So one is, can fecal microbiota transplant be done for stage 4 GvHD?
Oh yeah, almost 40% of our patients were stage 4.
Okay. And so there is another question by someone who has written that, don't you educate stool biofire before selecting the donor?
Yeah, I
Also,
actually,
very difficult to find a naive donor.
yeah.
My donor had salmonella and crypto, though non-symptomatic.
Yeah. No, so I wrote back saying that, I forgot to mention biofire. We do it. Although
Okay.
I somehow have a bad experience with biofire, respiratory or stool or anything, they just pick up anything. I feel it's too much of multiplexing. So I wonder if it's a good test, but nevertheless, we do it.
Okay. Dr. Tulika, do you have any questions? Thank you.
Thank you. So, yes, I just wanted to say that with Dr. Vanati, we've been having a very good collaboration, and we try to send all our patients to her even if they don't have any symptoms, because as she rightly said, it's very important to pick up things early, and having a good relationship is important because sometimes these patients will need only the ophthalmologist, eye drops, and special treatment. And sometimes we do actually have to increase the systemic therapy for the ocular chronic GvHD as well. The question that you had on the acute GvHD, ocular is very, very rare. It's in the literature, it's only 5 to 7%. So if that happens, you're pretty unlucky. But in chronic GvHD patients, almost 90% of them can have ophthalmological problems as well. So, having a close collaboration, having, one ophthalmologist that you send all your patients to that you can communicate with, I think is really very, very important, and it benefits the patient most. And there are specific indications where you will need to give systemic therapy along with the ophthalmological treatment that is being given.
Ma'am, can I ask one question to Dr. Vanity?
Yes, please go ahead.
This is one area, one GvHD which we don't understand anything about. Pulmonary GvHD we can still understand. We know a little bit about the treatment, but the eye is something which we don't understand at all. Now, there's one of our. I was in the hunt for somebody who could understand a little bit about ocular GvHD, because earlier when I was sending it to the general ophthalmologist, they were, patients just were not happy, and I could, understand that, the patient was not doing well. So then one day there's somebody who was a PGI pass out, and a good experience subsequently, and then he came in and he joined our center, and patient he understood ocular GvHD, and so he all our patients for the last decade have been going to him. So he left Pune and he's gone to Bombay now, and but still patients are not happy with the other people whom I refer to. So every time this guy comes back from Bombay, comes on a once or 2 weeks, all my patients, they visit him in his house, so he consults them there. So my question is, is it something? I mean, does it require a little bit of additional knowledge? Or do they just read up textbooks, read up articles, and will the ophthalmologist then understand whether there's any difference between how you manage ocular GvHD versus anything else? What exactly is it?
Yeah. I think the majority of patients who have ocular GvHD present as dry eye disease. The severity of the dry eye disease is what is going to be difficult to manage. And this is so even when you're managing dry eye disease due to other pathologies. If you're managing a dry eye disease because of rheumatoid arthritis, because of an SJS, because of a chemical injury, this is one ocular surface pathology which many people find very difficult to manage, because this is one where a blanket protocol usually does not work. First is lubricants. That is, you're actually replacing the tears which are not forming on the surface. And here, the immunological damage to the tear producing cells which are present, or the tear producing glands present on the ocular surface, and the lacrimal gland are progressively damaged because of the ongoing immune process. How much these glands are damaged, we now have ocular surface imaging, which can look at the mucus producing glands, which can look at the meibomian glands in the lids, which can say, and you would find surprisingly over 40, 50, 60% would be damaged in these patients, which is part of the ongoing disease process of the immunological damage itself. And this is what we are trying to understand, that can we in any way prophesize that this is a patient who's going to have a progressive damage of the mucosal cells despite the surface lubrication being optimal. And this is the research question which we are still putting across to all the surfaces. As long as they are having mild to moderate dry eye disease, can be treated by anybody. They do not need any other surface supplements here other than their lubricants, a minimal anti-inflammatory therapy. And now we also have immune modulators in terms of, I use varying percentages of cyclosporin, and I use tacrolimus over the lids, and it works fantastically for these patients, because once you put it inside, the burning sensation is so much they tend to stop using the medication. And you should also know how you would judicially use the various surface steroids. There are surface steroids of different percentages, but low potency and high potency steroids, which I mix and match according to the patient's morbidity and the symptom. You also should remember many of these dry eye disease patients have a psychosomatic component as well. So that also needs to be, the functional component needs to be identified and separated. The difficulty is in that 10% of ocular GvHD patient who have progressive cicatrizing conjunctivitis, which goes on to look like an OCP or an MMP. And these patients are the ones you need to step up their systemic immunosuppressant therapy. So that's when I send an SOS message to Tulika, Dr. Mahapatra, say, please step up their systemic immunosuppressants. And I've seen it helps 50% of the time, doesn't help 50% of the time, or it gets refractory after a 3 to 6 months of therapy here. And I've also seen these patients who have frequent relapses of ocular disease. It's something like a premonitory that their systems are going to get affected. And I think Dr. Tulika knows this. We lost a couple of patients. I think in the 2 or 3 of the thesis candidates, the patients were admitted with us, moved to you, and they subsequently passed away. So, it's very rare, so I cannot really generalize and say, but this is something which we did observe. So now we have got the answer to our research question of how can we stop it ongoing by giving something early. But I think I'm in too early a phase, and I have talks with Dr. Sandeep Jain, so I'm not at a liberty to reveal that right now. We need more evidence to, before we could probably share that with you. So we have immunomodulators. I vary the percentages. I use a combination of surface immunomodulators. I use tear lubricant replacements in terms of platelet lysate therapy here. And now what we find is the surface nets, the nuclear and the nuclear traps which are present on the surface. This is almost general. This is pathology basically, but then these nets which are present on the ocular surface, and when they are present, they are going to be one of the reasons why the person is having a progressive fibrosing conjunctivitis. So these need to be identified by your ocular surface expert. That is when probably an expert steps in.
Thank you, Dr. Vanika.
Yeah.
And so thank you all. And we finished the first part. Thank you, Dr. Sameer, and thank you, Chairperson Dr. Tulika, for this wonderful session.